Good morning, folks. My name is Dr. Banerjee, and I invite you all to the first 2015 XLPAD webcast. Today we have with us my close friend, Dr. Vijay Ramanath, who is an interventional cardiologist with Heartplace in Texas, in Dallas, and he's a clinical assistant professor of medicine at Texas A&M Health Science Center, College of Medicine. He has an illustrious background, and he is highly trained, initially starting from Boston University, and then following up his training at University of Pittsburgh, and then going off to University of Michigan for a research fellow in medicine, and finally doing his cardiology at Dartmouth Medical Center and his interventional cardiology University Hospital. So it's a great pleasure to have him today. His topic today is on iliac interventions. However, given the focus that we have for XLPAD webcast, his narrow focus in that area is going to be crossing strategies and outcomes of covered for iliac interventions. It is a great pleasure to have him here today with us, and I invite him to begin his talk in a few minutes. I just have two housekeeping announcements. Please mute your lines if you are connected, because it creates some artifact. And second is that if you have any questions during the meeting or afterwards, feel free to join in the discussion. You can actually join in either by raising your hand on the screen, or simply asking me as a host to give you time to ask a question or make a comment. And this is a fairly open forum, and the entire presentation is recorded. So take it away, Vijay. It's a delight to have you today.
Thanks, Subhash. Thanks very much for inviting me to participate in the webinar. It's only been a couple of months since we met each other, but I feel like I've known you for years. So good morning to everybody who's joined us. This morning we're going to be talking for the next 45 to 60 minutes, looking at crossing strategies and outcomes of both covered and uncovered stents, specifically for iliac endovascular interventions. So let's go ahead and begin. So first off, I have no disclosures that are relevant to this topic. So we begin with two cases. The first case is a very pleasant 66-year-old female who was referred to me for complaints of left thigh and calf claudication. She said she has significant symptoms while climbing stairs and just walking 50 feet on level ground. Her peripheral arterial disease risk factors included a prior history of tobacco use, although for the VA physicians listening to this, they'll probably think this is child's play with her 12-pack year history of smoking, and in fact she quit 20 years ago. She also has a history of hypertension, hyperlipidemia, and her current medications are fairly standard cardiac medications, including a low-dose aspirin, statin, fenofibrate, and a combination of calcium channel blocker and ACE inhibitor. On physical exam, her blood pressure was pretty well controlled at 132/80 and symmetric in both arms. Her heart rate was 80 and regular. Her cardiac exam was larger than remarkable, as was her pulmonary exam. Her vascular exam revealed 2+ carotid pulses bilaterally, with a 1+ right common femoral artery pulse with no bruit, and a minimal palpable left common femoral artery pulse as well. And her pedal pulses were both present, but markedly diminished bilaterally. Gastrointestinally wise, her abdomen was normal, and her musculoskeletal exam revealed no ulcerations or skin breakdown in her lower extremities, including her feet. So in my office, her non-invasive workup included the following. Her resting ABI in the right leg was 0.7, and her left leg resting ABI was 0.68. Her arterial duplex was quite interesting. Her common femoral arterial peak systolic velocity hovered around 200 with a biphasic waveform. However, her velocities in her superficial femoral artery on the right and her right popliteal artery were markedly diminished, as you'll notice here, all with monophasic waveforms. And her left SFA velocities were also markedly diminished, in fact, even more so than the right, as was her left popliteal velocities, again, all with a monophasic waveform. So this is all suggestive of pretty significant inflow disease involving involving her iliac system. So here is her initial angiogram. And by the way, if anybody cannot hear me clearly, please let me know. Here's her initial angiogram. So we had access in the right common femoral, as you can see, and this is a 5 French omniflush catheter. And the first thing you'll notice is that there's a fair amount of calcium lining the distal abdominal aorta. And you can notice that the omniflush catheter, in fact, is unable to maintain its normal contour due to the diffuse narrowing of the aorta. In addition, you'll notice that she has a high-grade right common iliac artery lesion that involves the distal abdominal aorta. And she has a fair amount of calcification involving the proximal mid-portion of her left common iliac artery. And in fact, there's an ostial occlusion that extends all the way from the beginning of the artery all the way down to almost the iliac bifurcation. So fairly extensive amount of disease. So as a fellow, I always found it kind of refreshing to review the task classification, and even as a physician in practice, I find it once in a while useful to review. So I thought I'd take a minute just to kind of review the task classification, especially for any fellows that are listening in today. As most classification systems, it's of course not a perfect system, but it works quite well. So it's obviously task A to type D lesions, type A being of course the more simplistic or more straightforward lesions, and then type D being the most common or the most complex disease involving the aortoiliac system. Type A lesions tend to be more unilateral or unilateral stenosis involving the common iliac artery, or a bilateral lesion involving the common iliac and the external iliac. Type B lesions tend to involve a little bit more of the aorta in addition to the common iliac artery. Type C lesions tend to be obviously more complex with bilateral iliac occlusions or bilateral external iliac stenoses. And then finally, type D involves significant occlusions involving the abdominal aorta, the common iliac arteries, and also significant disease that involves both the iliac system and the common femoral artery. So in our patient, some of you may disagree, but I felt she was kind of between a task B and maybe more, kind of favoring more of a task C sort of situation. So after discussing with her the results, in fact, before the procedure, she had told me that she really wanted to have this, prefer to have an endovascular strategy over an open bypass. She had a couple of family events coming up in the next few weeks, and she did not want to spend a lot of time recovering from major abdominal surgery. So with that in mind, we went ahead and in fact, I thought I could offer her a pretty good and durable endovascular therapy for the amount of disease she had. So we proceeded forward. So the right common femoral artery sheath that we had placed was a 6 French initially, and that was exchanged out for a 7 French sheath. And the purpose for that was that I was anticipating stenting her common iliac arteries. And we then proceeded with the access and left common femoral artery, and I placed a 7 French sheath directly. I then turned my attention to the left common iliac lesion, as clearly that was the more severe of the two. And I proceeded as follows. I advanced an 035 Anglide wire manufactured by Terumo, along with a Rubicon support catheter, and I was able to cross the distal cap and very quickly entered what looked to be the subintimal space. Not surprising given the amount of calcification that was there. I was not expecting to be able to remain true lumen throughout. Fortunately, however, though, I was able to re-enter the true lumen in the distal aorta, or ostium of the left common iliac artery, through which I was then able to exchange the wire for an 035 Rosen wire, which is a fairly stiff wire, over the Rubicon catheter. We then proceeded with the angioplasty of the left common iliac artery, and as typical in my style, I started with a fairly conservative balloon just to create a channel. So I started with an Admiral 5x40 balloon, as you can see here. Clearly undersized, but undersized by design. And again, you can really appreciate the amount of calcification and the fact that the balloon is, in fact, in the subintimal space within the proximal common iliac artery. So here's an image. Here's a video post angioplasty, and clearly, not an optimal result as expected. So additional angioplasty was then performed with a little bit more of an aggressive balloon, with a 7x40 balloon, and not surprising, again, still a suboptimal result, not surprising. So additional angioplasty was then performed, this time to left external iliac artery, again with the same Admiral 7x40 balloon. And then I turned my attention now to the right common iliac artery and performed some conservative balloon angioplasty with a 5x40 balloon, clearly undersized, but undersized by design, with the anticipation of stenting both lesions. So I then proceeded with stenting at this point. I felt I had created enough of a channel in both arteries to pass a stent. And so we then proceed with simultaneous kissing stent inflation with an ICAST 10x38 in the right common iliac artery, since it was a shorter lesion, and a 10x59 ICAST balloon-covered expandable covered stent in the left common iliac artery, again using the kissing stent technique. And clearly, as you can see, there's a significant waste in the stent balloon in the left common iliac artery, both in the proximal portion of the artery, as well as in the mid to distal portion of the artery. Post-dilatation of the stents were then performed with a 10 millimeter balloon in both arteries. And then following this, I did appreciate a 35 millimeter gradient across the left external iliac artery, which I felt compelled to definitively take care of. And so I placed a Cobalt Assurant 9x30 balloon expandable bare metal stent. And the reason for that was because I did not want to compromise or lose the left hypogastric artery, since it was quite patent and quite a large size artery on the initial angiogram. And so knowing that I would likely jail the left hypogastric artery, which I was okay with, I did not want to lose it completely, so hence the reason for a bare metal stent. So here's the final angiogram. I'll let you all judge for yourself as to the success of it, but I was quite pleased. As you'll see, the aorta is intact. It's a little difficult to appreciate on this angiogram, but I was able to manage to maintain the inferior mesenteric artery. There's good flow down the right common iliac artery, and there seems to be good quite good antegrade flow down the left common iliac artery, with preservation of the left hypogastric as well. So I was quite pleased, and you can also appreciate now that the left common filament artery does have a fair amount of calcification, as does the left common filament artery as well. So overall, I was quite pleased with the result. So she returned to my office 2 weeks later, and her post-procedure arterial duplex and ABIs revealed a marked improvement in her resting ABI on the right at 0.92, with a left ABI of 0.93. Her common femoral artery peak systolic velocities were largely unchanged, around 200, again with a biphasic waveform, but the velocities in both SFAs and both popliteal arteries were markedly improved, and now she actually had a triphasic waveform throughout. Unbeknownst to me, she did admit that 2 or 3 days prior to her post-op visit with me, she had walked an 18-hole golf course and was very, very excited that she had absolutely no claudication. I would have preferred that she had held off, but nonetheless, I was quite pleased with the result as well. So case number 2 is a 78-year-old Asian male who was actually introduced to me when he was admitted to the hospital with a non-STEMI. And so during the course of his exam, I did notice that he had no palpable right common femoral artery pulse and a diminished left common femoral artery pulse as well. At that point, I did ask him if he had any symptoms suggestive of claudication. In fact, he did, but he admitted that he had been having the symptoms for about 2 years, but did not mention to his primary care physician and never sought medical attention for it. So at any rate, we went and proceeded with an invasive strategy regarding his non-STEMI. He ended up having a coronary angiogram and subsequent PCI to his LAD. I typically do my catheterizations through the radial artery. However, in his case, I opted for the femoral because I wanted to see what his aorta and his iliac runoff looked like. So post-PCI, his aortogram revealed the following. So you'll notice that his distal abdominal aorta has fairly significant focal lesion in it. But what's most obvious is the fact that his right common iliac artery is occluded at its ostium with distal reconstitution via the left hypogastric artery of the distal left common iliac of the right distal common iliac artery, with a fair amount of diffuse disease in the right external iliac artery as well. And he also has diffuse disease involving the left common iliac artery, extending down to the left external iliac artery as well. You can also appreciate some disease involving the common femorals, particularly the left side here. So, approximately 2 to 3 weeks after his non-STEMI, he returned back to my office, and we discussed strategies for this. And he, given his age, he was not interested in considering any surgical approach, and he really opted for an endovascular technique if that was going to be possible at all. So this is how we proceeded, and I have to admit we proceeded in a fairly unconventional method, and that was largely due to the patient, for the reasons of the patient, which I'll describe in a second. So we essentially did it in a two-stage approach. The first stage, which wasn't the intent initially, was to we proceeded with endovascular repair of the left iliac system, and that was fairly straightforward. I ended up proceeding with PTA and stenting of his left common iliac artery with an ICAST 8x59 covered stent, balloon expandable covered stent. And for his left external iliac artery, I opted for a bare metal stent, which was self-expanding, a life stent 7x80 stent. My intent was to fix both the right and left iliac systems. However, due to the patient's level of discomfort, despite adequate sedation that his blood pressure and oxygenation would tolerate, we ended up stopping, and what I ended up doing was bringing him back in a couple of weeks, this time with general anesthesia, mostly for his level of comfort, and then proceeded with the right iliac system, because clearly that was a CTO, and that was going to be a little bit more of an involved case. So we brought him back a couple of weeks later with the intention of fixing his right iliac system, and we proceeded as follows. I used an angle glide wire once again, but this time I used a Navicross crossing catheter by Terumo. And as you can see here, I entered the subintimal space again in the proximal right common iliac artery. However, this time I was unable to cut through and enter the true lumen space within the abdominal aorta. And so after a couple of attempts, I then proceeded with re-entry. So what I ended up doing was withdrawing the glide wire and placing an 014 coronary wire, pro-water wire, by Asahi, and then using the Pioneer re-entry device, which is my personal preference for re-entry, mostly because of its ability to use IVUS visualization. I was able to successfully re-enter the abdominal aorta and then passed a 014 thunder wire into the abdominal aorta in a retrograde fashion in the true lumen space. That was confirmed by the IVUS. The 014 wire was then exchanged out for an 035 Rosen wire, and then we proceeded with PT and stenting. So again, we proceeded with a final simultaneous kissing balloon and stent technique, and what I ended up doing was deploying an ICAST 8x59 covered balloon expandable stent in the right common iliac artery, and using an 8x40 PTA balloon in the left common iliac artery and deploying them simultaneously in order to maintain the geometry of the previously placed left common iliac artery stent. And then I placed an additional atrium 8x38 covered stent in the distal right common iliac artery while placing the stent such that I was able to maintain and preserve the right internal iliac artery. He did have significant disease, as you noticed in the initial angiogram, particularly in the left common femoral artery, and so the very next day he went for a left common femoral artery endarterectomy with one of my surgical colleagues. I'm blessed to say that I'm fortunate enough to have a very close and good relationship with our vascular surgeons. We work very, very well together, which was somewhat refreshing compared to, I have to admit, my training days back as a fellow, where vascular surgeons and cardiologists didn't quite see eye to eye many times. Fortunately, in our institution here, we have a very, very good working relationship. So here, in follow-up, The patient came back to me in 2 weeks and had a complete resolution of his claudication, and in fact, a year and a half later, continues to remain both angina and claudication free, and is very, very pleased. Again, he's 78 years old, so his functional capacity is somewhat limited, but he's able to conduct all his activities of daily living. And his annual duplex ultrasound continues to show widely patent iliac stents, and his resting ABIs continue to remain within the essentially normal range, initially 0.7 and 0.75 to now 0.95 and 0.94. So overall, quite a gratifying result. All right, so now we'll kind of proceed now with the discussion portion of the presentation. So let's discuss symptomatic aortoiliac occlusive disease. Now, based on the guidelines and historically, both TASC-A and TASC-B lesions traditionally have been treated endovascularly, mostly because of its lower morbidity and mortality rate, and the fact that this strategy provides a very good, robust therapy for fairly straightforward lesions. For TASC-D and TASC-C lesions, which are obviously more complex, traditionally an open surgical or aorta by fem bypass has been traditionally recommended with obvious exceptions. Now, as I mentioned to you, my patients, I kind of classified them in the TASC-C, although you may be able to argue a TASC-B, but I would probably favor more of a TASC-C type of disease state. And so you could argue that what I did was against guideline recommendations. However, hopefully over the next 20-25 minutes, I'll be able to convince you that that what I provide for my patient was potentially a good option. So, looking at endovascular and surgical repair of aortoiliac disease, obviously there's been a number of studies done on this. However, this is just one study that I just wanted to show you that really proved or really brought endovascular therapy to the spotlight, into the limelight as a therapy that can really rival open bypass. This is a study looking at approximately 166 limbs, published back in 2008, and about 50% of the patients had TASC-D level disease, so the most complex level of disease. And what these authors found was that primary patency was fairly similar, at least up until the first 1 year post follow-up. But then after the 1 year mark, the curves begin to separate more and more, and by the 3-year follow-up period, clearly aorta by fem patency is higher. Nonetheless, secondary patency, though, is right on top of each other. They're essentially the same, as is rates of limb salvage. So for certain patients, endovascular therapy really can offer them a very good option, particularly for patients who are not great surgical candidates. So with that in mind, if you're willing to buy the fact that endovascular therapy is a good option, well then you might be convinced, or at least the literature suggests, that for endovascular therapy, both angioplasty and stenting does reveal superior patency rates compared to angioplasty alone, particularly for aortoiliac disease. I would guess that most of the people in the webinar would agree, if not all. And in fact, this is just one study illustrating the fact that in TASC-C and TASC-D lesions, the 1 year and 5 year patency rates for balloon angioplasty plus stenting is 98% and 77% respectively, compared to angioplasty alone, where the patency rates, at least in this study, was 83% at 1 year and 69% at 5 years. So if you believe that, then the next question is, well, within the stent realm, which is better, bare metal stents versus covered stents? And so when do you choose one stent versus the other? And then the second question is, well, is there a difference in patency rates and clinical outcomes between these two stent platforms? So, looking at covered stents for aortoiliac disease, there's been a number of studies, but unfortunately most of them, the vast majority of them, are very, very small, and in fact they're non-randomized studies. Just to kind of illustrate that point, I've just picked out 2 studies just to quickly discuss. This is a study of just 22 patients, very, very small, looking at patients who had TASC-C and TASC-D lesions specifically that were deemed too high risk for surgery. For the VA physicians listening in, this is probably all too familiar, where all the patients were male, and the average age was 68. So not too dissimilar from what we all see in clinical practice. And what they found was that at 24 months, the primary patency rate was quite good at 84%. but again, an extremely small population. A subsequent study published about 7 years later, not much different in terms of its population size, just 54 patients. This study looked at covered kissing stents versus bare metal stents in a kissing fashion at the aortic bifurcation. These patients, half of them received covered stents versus the other half approximately receiving bare metal stents. And at the 1 and 2 year primary patency rates, 92% for the covered stents, so quite good, versus 78% and 62% for bare metal stents, again, 1 year and 2 year primary patency rates. And that was found to be significant despite, again, a very small population size. So there seems to be some suggestion that cover stents in certain situations may actually be a very good option. In fact, maybe a better option than bare metal nitinol stents. But again, population sizes of 22 and 54, it's very difficult to hang your hat on that and base your clinical practice on such data. So the most talked about, or one of the most talked about studies looking at covered versus bare metal expandable stents is the COBEST trial, which is a prospective multi-center randomized trial comparing the Adventa V12 covered stent by Atrium, comparing to bare metal stents. And it wasn't just one bare metal stent that was used, but it was a heterogeneous population or multiple stents that were used within the study, including stents by Cordis, Boston Scientific, Medtronic, Cordis, and Bard. It was a study that was conducted from 2006 to 2008, and the primary study endpoints that were looked at using either duplex ultrasound, CT angio, or digital subtraction angiography was binary restenosis, which was defined by the authors as a 50% or more luminal diameter reduction, or a doubling of the peak systolic velocity, or a peak systolic velocity greater than 300 centimeters per second in the runoff vessel, meaning the distal femoral vessels. The other primary study endpoint was freedom from stent occlusion at 18 months of follow-up. Secondary endpoints included stent patency and, of course, the all familiar target vessel revascularization, being defined as any repeat angioplasty or bypass to the target vessel. And as typically the case, TVR was driven by clinical symptoms or by stress-induced symptoms in the way of a positive treadmill exercise ABI. Medical therapy in the trial was pretty consistent with what most of us do in clinical practice, which is a low dose of aspirin plus clopidogrel for a minimum of 1 month. And the procedural techniques, again, were pretty conventional techniques, which is the integrated approach with a crossover technique, or what I tend to favor, which is the retrograde or ipsilateral approach, as you saw in my 2 cases. And the lesions, of course, were crossed with an 018 or 035 system. Follow-up involved clinical evaluation and repeat ABIs at the 1, 6, 12, and 18 months, along with duplex ultrasound imaging. So here are the baseline characteristics, and I don't want to spend a lot of time with it, but suffice it to say that, as typically is seen in most of our practices, at least half the patients were smokers, either active or had a significant prior history. Over 50% of them were hypertensive, at least a quarter of them were diabetic, and they also had concomitant coronary disease as well, over a third of them. So pretty typical for patients with significant peripheral vascular disease. The baseline clinical and angiographic characteristics, again, this is a fairly busy table, so I'll direct your attention to what I find to be the most interesting aspect was the fact that almost 50% of the patients who had received the covered stent had either TAS-C or TAS-D level disease. So even though the patients were randomized, the patients who received the covered stent seemed to have overall more severe disease than the patients who had been randomized to the bare metal stent. So keep that in mind as we go forward. So the primary outcome within the trial, so freedom from binary stenosis, at 18 months follow-up, you'll notice that there was it seemed to favor, or certainly did favor, patients who received the covered stent. So throughout the follow-up period, from basically 1 month all the way to 18 months, you'll notice that freedom from binary restenosis favored patients who had received the V12 covered stent compared to bare metal stent. Stent occlusion also seemed to favor recipients of the covered stent. However, that was not found to be statistically significant. And what I found to be the most interesting of the study was that during subgroup analyses, for patients with TAS-C and TAS-D lesions, what was found was that freedom from binary restenosis was still higher for patients who had received the covered stent. So again, despite them having more complex disease, they seem to do better in terms of binary restenosis. But again, it's binary restenosis. It's not necessarily a clinical endpoint. And finally, freedom from target vessel revascularization also favored patients who had received the covered stent. Subhash, are you calling me? Can everybody hear me okay? Okay. All right, so to summarize the COBAST trial, covered stents as compared to bare metal stents in aortic iliac disease seem to be associated with lower rates of binary restenosis, lower rates of stent occlusion, and lower rates of TVR at 18 months of follow-up, despite having more complex lesions. Limitations of the trial, again, it's a very small trial. As cardiologists, we're used to trials of hundreds or thousands or tens of thousands of patients, but this is only 168 arteries total randomized. And again, multiple bare metal stent platforms were used. It wasn't just comparing one covered stent to one bare metal stent. It was a number of different bare metal stents utilized in the study, again, to the operator's discretion. So the next question then becomes does the COBAST trial data reflect real-world patients? And that's always a question that we always have to ask ourselves in any randomized controlled trial. Does that trial relate to the patients that we see in our clinical practice? And so retrospective studies often help complement the data that is presented in a randomized trial. And so this is a retrospective database trial out of University of California, where they looked at 162 patients and a total of 254 common iliac arteries treated either with a balloon expandable bare metal stent or a balloon expandable covered stent. The covered stent that was used was the iCast stent by Atrium, and the bare metal stents that were used in the patients in this registry included the Express stent by Boston Scientific, the OmniLink by Abbott, and the Genesis Pulmos by Cordis. Again, medical therapy pretty standard for most of us in clinical practice. Aspirin plus clopidogrel for 6 weeks minimum. And the endpoints that were looked at were primary patency, primary assisted patency, secondary patency, limb salvage, and finally survival. And obviously, again, a very, very, very busy data table, so I'll focus your attention on primary patency rates. What you'll notice is that the results of this study were in marked contrast to the COBAST trial. So overall, primary patency was quite good at 81% at 3 years. However, primary patency for the bare metal stent patients was 89% versus 72% primary patency in patients who had received a covered stent. So very interesting. The predictors of long-term patency was found to be on multivariate analysis found to be 12 months duration of dual antiplatelet therapy. In addition, the indication for the procedure was also found to be a predictor of long-term patency. That is to say, that patients who underwent the procedure for claudication seemed to have lower rates of patency versus patients who underwent the procedure for limb salvage purposes. Secondary patency in the study was very good at 97% at 3 years. However, again, there was still a significant difference between secondary patency rates of bare metal stent recipients versus covered stents. Bare metal stent patients' secondary patency was found to be 98% at 3 years versus 92% among the covered stent patients at again 3 years, and that was again statistically significant. So in stark contrast to the randomized trial. So to summarize, the COBAST trial, covered stents were associated with less binary restenosis and freedom from occlusion as compared to bare metal stents. And that was particularly true again in patients with more complex disease, i.e. the TAS-C and TAS-D subgroups. The retrospective study, however, seemed to suggest that bare metal stents were associated with better improved primary and secondary patency as compared to covered stents. So how does one interpret this data and incorporate it into their clinical practice? Well, I think we need to take a brief second, take a couple of steps back, and kind of analyze the two studies, as obviously they were conducted very differently. The retrospective study, of course, is one where the choice of covered stent versus the bare metal stent was made on a case-by-case basis. So that is to say that it was completely operator dependent. The patients were not randomized to one stent platform versus another. In addition, there's no description specifically of the complexity of the lesion, so there's no knowledge of how calcified the lesion was, if there was presence or absence of mural thrombus, whether the lesion was actually stenosis versus occlusion. And finally, as a retrospective study, it inherently has bias associated with it, which is often very difficult, if not impossible, to completely eliminate, particularly in the absence of patient randomization. The COBAST trial, in contrast, of course, was a randomized trial. However, it was a very small trial, and so it's difficult to base your clinical practice based on approximately 160 patients. So putting it all together, covered stents, I think most of us could agree that at the very least, it appears to be non-inferior to the bare metal stents in aortoiliac occlusive disease. And in fact, the COBAST trial was actually designed as a non-inferiority trial. Covered stents do appear to be superior compared to bare metal stents in aortic bifurcation lesions, for example, and that was proven both in the COBAST randomized trial in addition to some smaller studies as well. And that particularly is true the higher up you raise the bifurcation. So what was found in COBAST was that for patients where the stents were placed at least a centimeter or more above the aortic bifurcation, the patency rates seemed to be better for those patients when a covered stent was used. And finally, bare metal stents obviously have very, very good long-term patency rates as well, as high as 89% over a 3-year period, so it's hard to not reach for that stent as well during an endovascular strategy. So take-home points, and there's really 3 take-home points that I'd like you to take away, if you will. And that is to say that the use of bare metal stents versus covered stents, specifically for aortoiliac occlusive disease, should be based on 3 main things. 1, the complexity of the lesion or the lesions. Number 2, the location of the lesion. As I just mentioned to you, the aortic bifurcation is obviously very different from a focal lesion, stenosis, or occlusion in the external iliac artery, for example. And number 3, which I think is very, very important and often overlooked, is the overall operator's level of comfort and his or her practice pattern. Now, as you saw from my 2 cases, my style is generally to use a covered stent in the common iliac arteries, particularly when it involves the aortic bifurcation or the ostium of the lesions, or the ostium of the arteries. In the external iliac artery, where I'm concerned about preserving the hypogastric artery, obviously a bare metal stent is more advantageous. So obviously there's some data out there. It's clearly not perfect, but I'm hoping that in the not too distant future we'll have further insight once the Discover trial results have been released. So with that, I conclude, and I welcome any questions that anyone may have.
Well, thank you, Vijay. That was a fantastic presentation, a very detailed overview, and I really, really enjoyed the cases. So I invite each one of you to have any questions, and I just want to start off with one, very simple one. Is that I saw you picked a self-expanding stent and not a balloon-mounted stent, and I understand the reason behind it in this particular case, but just your comments regarding accuracy of implantation, especially if you're doing kissing stents in the ostium or in the origin of the iliac bifurcation.
Yeah, absolutely. So great question. So as a product of my training, and I fully agree with it, self-expanding stents are very good. There's obviously, there's always a chance that the stent deployment system can jump on you a little bit. It can migrate a millimeter or a little bit more. And obviously, in aortic bifurcation, placement is critical. It's really what I call a Mary Lou Retton moment. Not to date myself, but you really have to stick the landing. And so in that situation, balloon expandable stents, in my mind, are more advantageous because I can really control where the stent is going to be placed in that setting. In the second case where I deployed a life stent, which is a self-expanding stent, as you all know, in the external iliac artery, in that situation I had plenty of wiggle room, and so I wasn't too concerned about placement. And in that situation, I have to be honest with you, in the external iliac arteries, I tend to favor self-expanding stents just because I feel that the arteries are very fragile. They're not like the coronary arteries, which are much more muscular. There's a higher chance of dissection with a balloon expandable stent, and so for that reason, I tend to feel more comfortable with a self-expanding stent in the external iliac arteries. But again, when placement is critical, I do tend to favor a balloon expandable stent.
Thank you, Vijay. Any additional questions? I think you might receive some questions by email, and we'll forward them to you because we sometimes do receive some questions on the chat line and
Sure.
other forums. And please look out for the recording of the website of the presentation on the XLPAD website. And Vijay, if you can submit 2 questions with multiple choice, if you notice the XLPAD website, right next to your presentation, we will post those 2 questions along with your cases. So if you can share those with us, they'll make the presentation complete for all the viewers who have not been able to join us today. So again, thank you very much. If there are no additional questions, then please feel free to email us or write to us, and we'll forward those questions to Dr. Vijay Ramanath. I want to thank him for taking the time away from his busy practice early in the morning on a cold winter day in Dallas. And I appreciate very much this very complete and very thorough presentation, and look forward to his recording and to the CME questions and the case presentation on the XLPAD webcast. Thank you all for joining in, and a very happy New Year to you all. Thank you.
Thank you, Subhash.
Thank you.